Thank you. Well, good afternoon. It's a great pleasure to be here today, and thanks for the invitation to speak to you on really the whole issue of behavioral support units. I was asked to address this issue, which is obviously just a small part of this larger project. It is a great project, and the website has a huge amount of fantastic material on it, Ken. It was a bit hard to find. It was, but it's in the 8K. It's part of the 8KE website, right? Yeah. Or it's connected through it somehow. It's connected through it. It's really well worth going there. There's tons of really good stuff there. So before getting on to the whole question of units or special units to help manage responsive behaviors, this comes from the Canadian Coalition for Seniors Mental Health guideline on long-term care, mental health and long-term care. And it's the basic principles that promote and support mental health for all long-term care residents. And would all agree with these, but it is worth noting them. So individualized, person-centered care, respect for the family, a biopsychosocial care planning framework, a culture of caring that prioritizes quality of life, a social and physical environment that is responsive to changing needs, a focus on early intervention and prevention as well as treatment, and of course staff training and development, which is really critical in this area. So I'm involved in the International Psychogeriatric Association, and we were lucky enough last year to host the Congress, the World Congress of this organization in Montreal. And we had an expert meeting on mental health issues in nursing home care and long-term care. And as a result of that, just hot off the press, is the latest edition of International Psychogeriatrics, November 2010. And that whole issue of International Psychogeriatrics is devoted to mental health issues in long-term care. And I would suggest, if you're interested in the literature in this field, these are mostly review articles, so really cover a lot of different areas. And they range from looking at the latest evidence on psychosocial interventions for mental health issues and behavioral challenges to good assessment, screening. Staff education is a terrific paper here on the evidence for staff education in long-term care, et cetera, et cetera. And in addition to the articles from the Congress, there are a whole series of other articles that were also added to this edition. And these are the national guidelines for seniors from the Canadian Coalition for Seniors Mental Health. And there are 4 of these: depression, suicide prevention, delirium, and then the last one is focused on mental health issues in long-term care. I'm sure most of you are familiar. How many of you are familiar with this document? That's quite interesting, actually. Only a minority, so that's interesting. Maggie and myself were the co-chairs of this, creating this particular guideline, and this was the group that helped put them together, certainly an interdisciplinary group from across Canada. So this is from one of the papers in that issue of International Psychogeriatrics, and the lead author there is Dallas Seitz, who's sitting over there, who's now at Queen's University. And so this looked at the prevalence of psychiatric disorders or mental health disorders among older adults in long-term care homes, and it was really a review of the world literature. So we were able to look at 74 studies that met our criteria. And 30 of them focused on the prevalence of dementia, 9 on behavioral symptoms in dementia, and 26 on depression. So looking at the prevalence of dementia, there were 30 studies from across the world, although mostly from North America and Europe. They used 16 different diagnostic instruments. And the estimated prevalence of dementia in nursing homes varied between 12% and 95%, with a median prevalence of 58% from all the studies. I don't know, would you think 58% sounds low? How many think it's low from your homes? And do you think it's high? Or just about right? Just about right. Okay. So now BPSD is a term, it stands for the Behavioral and Psychological Symptoms of Dementia. It was a term coined by the IPA actually many years ago. So it's really referring to all of the different behavioral challenges, as well as other symptoms like depression and apathy that can be linked to the dementias. So there were only 9 studies reporting on the prevalence of behavioral symptoms in long-term care residents with dementia or cognitive impairment. And the prevalence was varied between 38% and 92%, and the median prevalence for any behavior was 78%. So very, very high, and we're certainly aware of that challenging behaviors are very, very common. Now, this is an important slide, and it's from Henry Brodady from Australia, and so I think it's very useful. So it really looks at the different degrees of BPSD, or behavioral symptoms. And so really what it's saying is that at the bottom we've got individuals with dementia without any behavioral disturbance, or actually with no dementia at all, and then no symptoms at all, and then mild, and then moderate, and then severe, and then very severe, and then extreme at the top. And I think when we're talking in this field, we often lump all these individuals together and come up with strategies or ideas or opinions as though they're all a single group. So I would really say, if you take one thing away from my talk, remember this pyramid, because I think it's well worth remembering when we're looking at service planning or improving the system. Who are we talking about? Are we talking about these folks? Or are we talking about the few individuals with extreme behavioral disturbance who really need to be cared for a while in a psychiatric setting? Or all the groups in between? And I think when we're talking about behavioral support units, we're probably talking somewhere like around tier 5, so around there. At least that's my thought. And I did want to mention depression, because depression often gets neglected in this population. A lot of the focus is often on the agitation, the aggression, the challenging responsive behaviors. And people with depression, they may be agitated, but they're usually quiet and withdrawn. And often there's less focus on those individuals. But we do know that the prevalence is very, very high. In our review, there were 26 studies reporting on the prevalence of major depression or depressive symptoms, again from around the world. And so the prevalence of major depression, major clinical depression in long-term care ranged from 4%, which is low, to 25%. The prevalence of depressive symptoms varied between 29% and 82%. But it doesn't matter. I think if you collectively take this evidence, then we certainly know that depressive symptoms are extremely common, and I think most people would find a figure of around 20% for major depression in long-term care to be about right. So focusing on the aggression and behavior disturbance and agitation, the causes, the etiology we know is multifold, and we really need to think about a biopsychosocial approach here. If we get caught up in thinking that the only issue is to think about what the meaning of the behavior is, I think that quite honestly, I think that's a mistake. I mean, we've got to look for the meaning and try to understand the individual and recognize them as unique. But if the cause is a urinary tract infection, well, I guess that's a meaning, but it's really important to keep an open mind as to what the causes are. So, but caregiver-related etiology is very important, and we certainly know that the interaction between the caregiver and the resident is critical. There are environmental factors, and Maggie will be talking a lot about the environment. Manifestations of a medical disorder, so ruling out pain and discomfort, psychiatric comorbidity, delirium, medication side effects, and indeed neurotransmitter changes in the brain are all important.
Are those in any particular order?
No, they're not in any order. They're all critically important, I would say. Although it's a good place to start with the caregiver, I think, and the interaction. That is a good place to start looking. So this is a document that's on the website, and it's called Building a Better System, Caring for Older Individuals with Aggressive Behaviors in Long-Term Care Homes. And it actually looks at a system-wide approach. So I think this is a very, very useful document. It involved a survey, interviews with key informants across Ontario. It was extremely well done, and it's filled with clear recommendations about where we should move forward. So I'm not sure what the status of this document is in the overall strategy, but I thought it was a great document.